So good evening, everyone, and welcome to one of the Plant-Based Health Professionals UK webinars. For those of you who are new to the webinar programme, my name is Rahini Bajekor, and I'm a nutritionist and communications lead at Plant-Based Health Professionals UK, a community interest group dedicated to promoting the benefits of a sustainable and healthy plant-based diet to health professionals and the public alike. So tonight we have a very hotly requested webinar for over a year since we started our webinar programme, and it's on bowel cancer, diet and the gut microbiome with our very own ambassador, Dr. Alan Desmond, who's a consultant gastroenterologist and author of The Plant-Based Diet Revolution. These webinars wouldn't be possible without the support of our brilliant sponsors, including ProVeg International and veganfitness.com, who kindly lend us their Zoom platform. We're also CPD accredited with the British Society of Lifestyle Medicine and CME accredited with the American for the 5-year lifestyle medicine maintenance of certification as well. So everyone who is attending tonight will get a CPD certificate in their inbox tomorrow. Do join us in 2 weeks' time, as we'll have an incredible session with legendary dietitian Brenda Davis on plant-based diets in the prevention, treatment and remission of type 2 diabetes. We had a brilliant webinar covering type 2 diabetes and cardiovascular disease in South Asians a couple of weeks ago. So this is going to be a great follow-on the how and how we can apply plant-based diets in clinical practice as well as individuals, for those of you who aren't healthcare professionals, but who personally have type 2 diabetes or have loved ones with type 2 diabetes. This is free to attend, so do go and sign up on our website after this session. And lastly, do support our work if you can. Membership is open to everyone, not just healthcare professionals, and you can visit pbhp.uk to subscribe to our free weekly newsletter. Donations make a huge difference to our advocacy work, and you can visit pbhp.uk/donate if you're able to donate towards these webinars and our other activities. And we're also active on social media on Facebook, Instagram and Twitter. So last but not least, I'd like to welcome Dr. Alan Desmond to present for the evening. We're going to have around a 35-40 minute presentation followed by a live Q&A. So if you have any questions at any point, do dive down to the bottom of the screen and click on the Q&A box, as that helps me when I'm moderating the Q&A. Dr. Alan Desmond came out with his brilliant first book in January this year, which is a must read. I have it right behind me, The Plant-Based Diet Revolution, which is packed with tips for a healthy gut microbiome with brilliant recipes that are packed with flavor and really made of really wholesome but easily accessible ingredients. So now, Alan, if you're there, I would welcome you to start sharing the screen and see you in a bit for the Q&A.
Okay, great. Thank you, Rahini, for such a lovely introduction. I'm Dr. Alan Desmond, and the topic of tonight's webinar, diet, lifestyle, and colorectal cancer. What should we tell our patients? Colorectal cancer is the third most common cancer diagnosed in both men and women in the UK and the United States. In the US, it affects about 1 in 23 men and 1 in 25 women in their lifetime. In the UK, it affects about 1 in 15 men and 1 in 18 women in their lifetime. And I apologize for all these US statistics, but I gave this presentation for a US audience just recently. 150,000 new diagnoses of colorectal cancer in the US every year. In the UK, that number is 43,000. And in both the UK and the US, it is our second leading cause of cancer death. This is what a relatively early cancer looks like when we see it through a colonoscope, a site that unfortunately I see more than once per week. As a gastroenterologist, I have this conversation with patients all the time. Immediately after colonoscopy, I'll need to sit down with a family member and the patient and explain to them that I've just diagnosed them with colorectal cancer. Now, the overall 5-year survival rate is 63%, which is reasonably good in terms of cancers to be diagnosed with. And if we find it at an early stage, the survival rate is 90%. But I'm very aware that every time I have this conversation with a patient, that there are 1 million people having this conversation with their doctor every year around the world. And even if the cancer has been found at a very early stage, it is still a life-changing event to be diagnosed with colorectal cancer. So 42,000 people are diagnosed with colorectal cancer every year in the UK. Every individual in this picture represents 1,000 people diagnosed with colorectal cancer in the UK in the last 12 months. We live in a country where colorectal cancer is so common that we have a colorectal cancer screening program. And we have posters like these in public bathrooms and GP practices reminding people to take part in bowel cancer screening. And if they see any blood or looser stool in the toilet, that they should speak to their doctor. And the reason we take these measures is because it takes about 15 years for a polyp to turn into a cancer. So there is definitely a role for prevention and early detection. But of course, not every country in the world has these tremendously high rates of colorectal cancer. In fact, there's a greater than 10-fold difference in colorectal cancer incidence between nations. On the left-hand side here, you see that if you live in a high-income country, you are far more likely to develop colorectal cancer. And if you live in a low-income country, colorectal cancer rates are very low. Because lower income countries are inexorably becoming higher in income and embracing this standard Western approach to food and lifestyle, the global burden of colorectal cancer is expected to increase by 60% to result in more than 2.2 million new cases and 1.1 million deaths per year by the year 2030. In Europe, what we have seen, thanks to effective screening programs, is that in older individuals, rates of colorectal cancer are starting to tail off. However, worryingly, on an annual basis since the 1990s, we've been seeing an increase in colorectal cancer among European adults aged between 20 to 39 years since the 1990s. In the US right now, 1 in 8 cases of colorectal cancer are diagnosed in individuals less than 50 years of age. And of course, we all remember the tragic case of Chadwick Boseman, who passed away last year, aged 39, having been diagnosed with stage 3 colorectal cancer. Sadly, any gastroenterologist working in the UK will know that they are now having conversations with young people diagnosed with colorectal cancer more often than ever. Chadwick Boseman's case was obviously tragic and places a spotlight on how tragic a diagnosis can be. But again, remember, 42,000 people come through this diagnosis every year in the UK. So before I go into the evidence, I just want to point out that I'm drawing predominantly on a very recent paper that was published in the literature coming out of the Netherlands and McGill University Health Centre in Quebec. The hierarchy of medical evidence puts meta-analyses and systematic reviews at the top of the pyramid. This is the strongest level of medical evidence. In fact, this is an umbrella review which combines the results of multiple meta-analyses, 80 systematic reviews and meta-analyses in total, to really give us some evidence-based answers on what about food and colorectal cancer in the average risk population. But let's remember, folks, that the average risk population does not eat a very healthy diet at all. On the left-hand side, this is, I'm sure you'll be familiar with, the Planetary Health Plate as published by the Eat Lancet report in 2019, estimated that we could prevent 11 million deaths per year if we could get everybody to eat like this. The little dotted line here is the level of safe consumption of each of these foods. Here is how people eat in the US right now, very comparable to how we eat in the UK, Ireland, and other high-income countries. As you can see, on most food groups, we are way off the dotted line. Fruits, vegetables, and whole grains are hardly consumed at all, whereas poultry, eggs, and meat, particularly red meat, are pretty much off the chart. If we were to draw the analogy to the speed limit, if the level of safe consumption is 60 miles per hour, right now in the US and the UK, when it comes to meat consumption, we are driving at an average 382 miles per hour. So let's just put that in context as we look at the dietary components that increase or reduce risk in an average risk population. Let's start with fiber. Dietary fiber, which we only get from plants, is protective. People who eat the most fiber in the Western world reduce their risk of colorectal cancer by between 12 and 24%. No surprise, more plants equals more short-chain fatty acids, more phytonutrients, more antioxidants, etc. And there is a dose response curve. So every 10 grams of whole grain fiber consumed per day reduces one's lifetime risk by between 10 and 17%. So what can we tell our patients about fiber? Dietary fiber is protective, but the optimal dose and duration of intake is difficult to define. And this is largely because in most of these studies, we're looking at populations where fiber intake ranges from between 6 to 21.4 grams per day. In high-income countries, most people don't reach the minimum, the modest minimum of 30 grams per day. What about fruits, vegetables, and legumes? Excuse me. So fruits and vegetables, especially legumes, are great sources of dietary protein, vitamin E, vitamin B, selenium, and lignans, which may have each individually may have potential cancer preventive effects. So it's not surprising that eating more fruits and vegetables are protective. In Western populations, those people who eat the most vegetables may reduce their personal risk of developing colorectal cancer by more than half. And again, we have a dose response curve. For every 100 grams of fruits and vegetables eaten daily, the risk reduces by 11%. So that's just half an apple a day to keep the oncologist away. Higher consumers of legumes, cabbage, and cruciferous vegetables in a high-income country, those individuals may reduce their personal risk of colorectal cancer by between 9 and 24%. I've got to give special mention to the wonderful soybean. Soybeans have all the benefits of legumes plus the additional benefits of isoflavones, which may act directly on the gut lining to impact on cancer initiation and progression. Excuse me. Regular consumers of legumes, including soybeans, particularly soybeans, may reduce their risk of developing colorectal cancer between 9 and 27%. So real benefits here just by eating soybeans on the regular. Something I'm asked about all the time when it comes to colorectal cancer prevention: are dairy products protective? So we have 3 observational meta-analyses published from 2012 to 2017, which are of high quality, a total of 434 high quality studies included. And what we find is that any 400 gram per day increase in dairy consumption is associated with a 10 to 26% reduction in colorectal cancer. The reported benefits seem to be limited to dairy consumption of milk, no benefit from cheese consumption. But let's put this in context. Here are my caveats. This isn't about dairy, it's about calcium. We know that calcium can bind carcinogenic secondary bile acids and ionized fatty acids and inactivate them and combat the pro-carcinogenic effects that these things exert on the lining of our gut. We know from the Nurses' Health Study and the Health Professional Follow-up Study, data published in 2002, that simply consuming more than 700 milligrams of calcium per day significantly reduces one's risk of colorectal cancer. So when we are advising our patients to consume more calcium to reduce the risk of colorectal cancer, why not advise them to eat foods that increase their calcium intake and their fiber intake and their legume intake together? Beans, greens, dates, calcium set tofu, etc. This is really important because we need to look at our patients as whole people. It's not just about colorectal cancer risk, and we know that consuming dairy products is strongly implicated in breast cancer, prostate cancer, endometrial, and other cancers. Now, here is a forest plot showing the potential reduction of colorectal cancer linked to regular dairy consumption, and that data is real. But I take the same approach as the World Cancer Research Fund in their patient information website and program, How to Protect Yourself Against Bowel Cancer. Yes, in Western populations, dairy consumption does correlate with reduced risk of colorectal cancer. However, because we are unsure about the effect on other cancers, we do not make any recommendation about dairy products. what about fish and omega-3 oils? I get asked this one a lot as well. So the big data tells us that the impact of fish and omega-3 intake on colorectal cancer risk is of uncertain benefit. We see disparate results, not convincing as to whether there's any protective effect for fish and omega-3 consumption in preventing colorectal cancer. Any gastroenterologists in the audience may be aware already of the UK seafood polyp prevention trial, which ran from 2011 to 2016, a huge, well-funded randomized control trial giving 2 grams of EPA from fish oil did not reduce the risk of colorectal adenoma formation. And that's in keeping with the big data. Fish and omega-3 intake do not seem to reduce one's risk of colorectal cancer. Among the other foods and supplements that seem to have no effect on colorectal cancer risk are giving individual vitamin and antioxidant supplements, giving beta-carotene supplementation, giving selenium supplementation, tea, garlic, allium, even vitamin D supplementation is not convincing, nor is vitamin D and calcium supplementation alone. There are 2 dietary components that the evidence tells us increase our risk of developing colorectal cancer. They're both in this picture. It's not the tomato. Has anybody guessed? The first one is alcohol. Alcohol use increases the risk of colorectal cancer. And again, there is a dose-response relationship. Even drinking 1 beverage per day may increase our risk between 2 and 13%. Modest drinkers, 17 to 23% increased risk. Heavy drinkers, more than 4 drinks per day, increased risk of 38 to 58%. Look, there's no surprise here. We know that alcohol is carcinogenic. And bad news for all the gentlemen in the audience, the increased risk associated with alcohol consumption seems to be even more marked in males. This is a picture of a gentleman who just heard the news. And the only other food or component that is linked to an increased risk of colorectal cancer is meat. 7 meta-analysis of observational studies assessed meat and colorectal cancer risk. Again, we have a dose response or a dose effect study or a dose response curve. Every 100 grams per day of total or red meat increases one's risk of colorectal cancer by 10 to 30%. And there is no clear limit threshold identifiable. This means that the more meat, the more cancer. The less meat, the less cancer. And to quote the Eat Lancet report in 2019, when it comes to red meat, the safest the most likely safe level of consumption is 0 grams per day, especially when it was replaced with healthy plant-based sources of protein. Every 25 grams of processed meat per day, that's 1 sausage or 1 strip of bacon, increases your risk by 4 to 12%. That means 2 sausages or 2 strips of bacon increases your risk by 8 to 24%. And in the US and the UK, we consume an average of 25 to 27 grams of processed meat per day on average. Of course, this shouldn't surprise us. We've known this for a long time. And the data does show us, some data does show us that vegetarians are less likely to develop colorectal cancer. So this is data from the Adventist Health Study 2, 77,000 adults followed for 7.3 years, reported in 2015. Among the Seventh-day Adventists, we know that meat consumption is low at 54 grams per day. That's about 17 kilos per year compared to the US average of 100 kilos per year. 30% fewer cases of colorectal cancer. And among the Adventists who do not consume meat at all, 36.6% fewer cases of colorectal cancer, because those Adventists eat less meat or no meat at all, but are also consuming more fiber, more legumes, and more soybeans. This is old data from Greece, a case control study. Individuals eating a high vegetable, low meat traditional Mediterranean diet versus those who were eating a westernized high meat, low vegetable diet, the risk of colorectal cancer differed by a factor of 8. And this data published by Walter Willett and colleagues back in 1990, comparing colorectal cancer risk and meat consumption among 89,000 healthy women followed for just 6 years, Those who consumed red meat daily versus once a month were 2.5 times more likely to develop colorectal cancer. But again, this shouldn't surprise us. Since 2015, we've known that processed meat causes colorectal cancer. The World Health Organization classified processed meat as a class 1 carcinogen alongside asbestos in cigarettes, known to cause colorectal cancer. They classified red meat as a class 2A carcinogen, probably causes colorectal cancer in humans. But of course, we're still waiting patiently for that warning to appear on packets of bacon. This data was confirmed by the data published just last year by the UK Biobank out of Oxford. 175,000 adults followed for 5.7 years. Processed meat twice a week versus never increases one's risk by 19%. That's just eating bacon twice per week. And this data indicated that eating red and processed meat at the current UK level of consumption, which is 70 grams per day, increases the UK's population colon cancer risk by 20%, meaning that red and processed meat are causing 8,500 cases of colorectal cancer per year in the UK. 50% of those people will have died within 5 years of diagnosis. Now, there's lots of reasons why meat causes colorectal cancer. The heme iron, the heterocyclic amines, polycyclic aromatic hydrocarbons, the nitrates and nitrites, which can occur naturally in meat, but are also added to processed meat to preserve their color, all contribute to inflammation, DNA damage, and precancerous changes. What about the gut microbiome? 100 trillion microbes, bacteria, viruses, yeasts, and archaea, 10 times more cells and 150 times more genetic material than our human body. Our gut microbiome begins to form at birth or maybe even just before birth. It helps us to digest our first meal. It is crucial to the development of a healthy GI tract, immune system, and body, and has been described as a control center for human biology. It mostly resides in our colon. So what role does it play in colorectal cancer? Well, in order to develop colorectal cancer, in most cases, the lining of the gut, the normal epithelium, has to go through a number of changes. We get hyperproliferative early changes. We then get the formation of an adenoma, a polyp, which someone like me may remove whilst doing a colonoscopy. And that can progress to form an adenocarcinoma, a malignancy. And through every step of the way, our immune system and our microbes, these little squiggly fellows here, gut microbial microbes, are interacting with those cells at every single stage. This paper, published in 2018 out of Japan, summarized it in the title: The Association of Diet, Gut Microbiota, and Colorectal Cancer. What we eat may imply what we get. Because when we eat red meat, processed meat, and animal fat, we digest whatever nutrients are present, and we are left with the residue which reaches our gut microbiome in our large bowel. And when we consume this standard Western diet, the residue that arrives is bile acids, animal-based protein, and very few polyphenols or fiber. This feeds the gut microbes that enjoy metabolizing bile acids and animal protein. And the postbiotic substances that this gives us include carcinogenic secondary bile acids, ammonia, phenolics, hydrogen sulfide gas, which is directly implicated in causing gut inflammation. And we also get relatively few short chain fatty acids, which are incredibly important for maintaining our gut health, and in fact provide 70% of the energy needs to our colonic epithelial cells. In short, we produce a gut microbial environment that is conducive to inflammatory and carcinogenic effects with barrier dysfunction, epithelial proliferation, inflammation, DNA damage, and genotoxicity. In contrast, so we have built a gut microbial environment that is conducive to colorectal cancer. In contrast, when we eat fruits and vegetables and whole grains, now we have very few bile acids. We are low fat. We've got lots of polyphenols, lots of fiber. We have got plant-based protein. We are feeding a different set of gut microbes that produce a different set of postbiotics. We get more short-chain fatty acids and vitamins and more antioxidants. We get far fewer secondary bile acids and hydrogen sulfide gas, the eggy gas, pro-inflammatory gas. We now have mucosal anti-inflammatory and anti-carcinogenic effects. We have regulated cell metabolism and microbiota homeostasis. We have genetic regulation, anti-proliferative effects. Mucosal health and defense are promoted. In short, we produce a gut microbial environment that is not conducive to chronic inflammation or to colorectal cancer. In 2019, the journal Nature published 2 deep dives into the gut microbiome amongst individuals diagnosed with colorectal cancer compared to controls. This was a fascinating paper because across multiple populations in multiple countries with multiple food cultures, they found consistent gut microbial signatures in patients diagnosed with colorectal cancer that were less likely to be present in controls. The colorectal cancer microbiome is substantially enriched with the bacteria that thrive on meat and fat, with a higher capacity to produce carcinogenic secondary bile acids and pro-inflammatory TMA. The colorectal cancer microbiome contains fewer of the bacteria that thrive on fruit, vegetables, and starches. Last year, Angelis et al. Published a deep dive into the functions of the human intestinal microbiome amongst individuals who eat a plant-based diet versus omnivores. The plant-based gut microbiome produces more short-chain fatty acids than meat eaters, is better at suppressing the growth of colon cancer cells, contains far lower levels of secondary bile acids, and the plant-based gut microbiome lacks the ability to metabolize carnitine from meat and choline from eggs to generate TMAO, which is good news because individuals with elevated serum TMAO are 3.5 times more likely to develop colorectal cancer. And in individuals with colorectal cancer, the individuals with high preoperative serum TMAO have significantly shorter disease-free survival. Of course, we've known about this for years. Colorectal cancer, bowel cancer, was one of Dr. Dennis Burkitt's original diseases characteristic of Western civilization. In this paper published in 1973, he pointed out that bowel cancer was extremely rare in developing countries in Africa and Asia. And we know that immigrants who move from low-income countries take on the risk of the country they move to, and they do this within 2 generations. Genetics do not change in 2 generations, but diet and lifestyle do. Quote, colorectal cancer incidence in the offspring of Japanese migrants to the US now approaches or surpasses that in the white population and is 3 or 4 times higher than among the Japanese in Japan. Now, when you move from a low income to a high income country, there's a lot of changes. Cigarettes, alcohol, chemicals, infections, antibiotics, etc. might all play a role, but what about diet? Well, these US researchers set out to study that and published this incredible paper in 2015. If you only read one of the papers that I've mentioned tonight, please read this one. Fat, fiber, and cancer risk in African Americans and rural Africans. So we know that Americans of African descent have a significantly increased risk of developing colorectal cancer, whereas rural Africans hardly ever get colorectal cancer. Rates are extremely low. So with this knowledge, these researchers based in Pittsburgh, Pennsylvania, recruited 20 healthy African American adults and 20 healthy rural African adults. They did an in-depth assessment of everybody's colorectal cancer risk. Everyone had a colonoscopy and a gut microbiome analysis. Among the Americans, 45% already had precancerous adenomas in their large bowel. Among the rural Africans, nobody had a precancerous polyp. They didn't find one polyp in the 20 volunteers. And they then looked at their mucosal proliferation rate, which is a marker of colorectal cancer risk, their levels of short-chain fatty acid producing bacteria, their fecal butyrate, which is one of the main short-chain fatty acids. They also looked at the bile-loving bacteria within the gut microbiome, because those bacteria produce the secondary bile acids that we know are carcinogenic. Across the board, the Americans had a high colorectal cancer risk profile. Across the board, the rural Africans had a low colorectal cancer risk profile. They looked at their diet. The Americans, typical diet, sausage and pancakes, spaghetti, meatballs, hot dogs, beans, roast beef and mashed potato, compared to the rural Africans who were eating things like spinach, red pepper and onions, corn fritters, mango, kale salad and African potato salad. So what did they do? A food swap. So now for 2 weeks, the Americans would be eating all these great plant-based options and the Africans would be eating all these meat-based options. With their new approach to food, the Americans were now consuming 55 grams of fiber per day and getting 70% of the calories from whole carbohydrates. After 2 weeks of this dietary change, everybody had a colonoscopy, had their mucosal proliferation rate measured, and had their gut microbiome analyzed. The researchers were astounded. In just 2 weeks, the risk profiles had flipped. The Americans now had the same profile that the Africans had started with, a very low colorectal cancer risk profile. Whereas the rural Africans who'd taken on an American-style diet now had a high colorectal cancer risk profile across the board. We have shown in individuals from high risk and from low risk cancer populations that change in the food content of fiber and fat had remarkable effects on their colonic microbiota and metabolome within 2 weeks. And critically, that these changes were associated with significant changes in mucosal inflammation and inflammation. It's never too late to make a healthy change in your diet. This paper, published in 2018, looked at cancer survivorship among individuals diagnosed with colon cancer. In the US, we have the American Cancer Society guidelines for living healthily with cancer. These guidelines promote physical activity, the avoidance of alcohol and cigarettes, eating a plant-rich diet, exceeding the 5-a-day requirement of fruits and vegetables and whole grains, and avoiding red and processed meat. 900 individuals with stage 3 colorectal cancer were recruited. The 5-year survival rate amongst the individuals with low adherence to the guidelines was 65%, which is what we expect from the literature. Among the individuals who had high adherence, the survival at 5 years was increased to 81%. Now that's a big increase. If you look up that paper, it's really fascinating. You will see in the analysis of that paper that avoiding red and processed meat did not seem to have a major effect, which would surprise anyone, because we know that anyone who avoids red and processed meat over 5 years, you would expect to see a survival benefit, whether they have cancer or not. However, in the detail of that study, you can see that the individuals who avoided red and processed meat were consuming 4 servings per week. The individuals who didn't avoid red and processed meat were consuming 7 servings per week. So in my opinion, that dose reduction is not clinically significant. So, diet, lifestyle, colorectal cancer. What should we tell our patients? The majority of cases of colorectal cancer are preventable through a healthy diet and lifestyle. Only 5 to 10% of colorectal cancers are due to hereditary syndromes, such as Lynch syndrome or FAP. 90% of colorectal cancer cases are sporadic and are caused by a complex interplay between environmental factors, genetic susceptibility, which all determine the initiation and development of the cancer. What can you do? Don't smoke. Minimize or avoid alcohol. When it comes to food, minimize or completely avoid red and processed meat. Maximize your fruits, vegetables, whole grains, and legumes. Eat foods made from soybeans and try to eat them several times a week. Eat calcium-rich, fiber-rich foods. A whole food plant-based diet ticks all the right boxes to reduce one's risk of colorectal cancer. And as we've covered this evening, it's never too early or too late to make the change. Prevention and early detection remain incredibly important. Take part in screening programs when you are invited. In the US, screening begins at the age of 45. In the UK, it's 55. Low risk is not no risk. And if you have symptoms, even if you have a healthy diet and lifestyle, if you have symptoms, please talk to your doctor and get checked. Thank you.
That was incredible. I'm already had so many questions pouring in, but there was so much information in that. I learned so much. I feel like I only found out recently that bowel cancer is the 4th most common cancer in the UK, but it's amazing how little we talk about it, really. It's so common, as you've talked about, and there are so many.
You're right. I think like a lot of gut health issues, really, there's a stigma about it. Look, everybody poos, but nobody talks about it. And I think it comes to that as well. People talk about bowel cancer, and I guess all cancers, often in hushed tones. They're afraid to mention them. But it's a shame, because I think if people talked about the symptoms of colorectal cancer more, then people would be more likely to get checked and would be more likely to find out what they can do to reduce their risk. And particularly for individuals who have a family history or have previously had polyps themselves, this information is stuff they should know, right?
Absolutely. And you're a consultant gastroenterologist in the NHS, and you have your own private clinic as well. How do you encourage your patients to make a shift towards the foods that you've talked about in this presentation, towards a healthy plant-based diet and away from meat and the other ultra-processed foods that increase your risk of colorectal cancer?
Well, when we're speaking about colorectal cancer specifically, usually in my clinical practice, you're already dealing with someone who's highly motivated. They are highly motivated because, for whatever reason, either they've had a worrying symptom, or they have a family history, or they've previously had polyps, or maybe a friend of theirs has had a diagnosis of colorectal cancer. They are already motivated enough to come and see a gastroenterologist. And they may already be motivated enough to have a colonoscopy. If they're within the bowel cancer screening program, they have already opted in. They've done a poo test, they've done a fecal immune test to look for blood loss. So it's already a very motivated population, really. So as a doctor, I feel when we have people who are so motivated to reduce their risk that they've already jumped through all of these hoops, we need to share this information with them. And I generally experience that people are very, very open to receiving that information. I had a consultation with a gentleman earlier today who I hope is watching this webinar, because I gave him the details. And that gentleman has a close family history of colorectal cancer. And he's been very motivated throughout his life to reduce his personal risk. And in the last 20 years, he's had maybe 18 or 19 colonoscopies and flexible sigmoidoscopies. But I don't think anyone ever spoke to him about diet and lifestyle. And it is so important. I'm really proud that at my NHS hospital, every person who comes for a bowel cancer screening program colonoscopy, 2 weeks later, they receive a glossy brochure explaining the science that we just discussed.
That's incredible. Yes, and that's why your book is so helpful, because you have all those recipes, you have those practical tips on how to stock your kitchen, really breaking it down and making it much more accessible to people, because it can be hard to know that when you're at the start of things. It's hard to know where to start. It can feel like such a big change, but it doesn't need to be that way. And what about when you have the diagnosis? So you talked a little bit about this, and this is obviously what you do on a day-to-day basis, but once you have a diagnosis of colorectal cancer, what can the impact of dietary changes be, and lifestyle changes, of course, as well?
Well, we've already seen the data I just showed you, that we can get very substantial increases in survivorship. So increasing your 5-year survival statistically, and I know, look, these 5-year survival statistics always strike me as being incredibly cold and actuarial, but this is what oncologists look at when they're deciding on treatments, right? They look at 5-year survival benefit. So if we've got a 5-year survival benefit, they can get your 5-year survival with colorectal cancer, even a relatively advanced colorectal cancer, from 60% to 80%, that's huge. If that was a pharmaceutical, it would be licensed in the morning.
Absolutely. And what when it comes to exercise, because I know from following you on Instagram for many years that you are very passionate about diet as well as all the other lifestyle pillars, bringing in exercise and so on, what is the effect, the dosage effect of exercise on colorectal cancer risk?
So that question actually features in the paper that I mentioned earlier on the ACS guidelines. And I'm going to admit here, I can't give you the answer to that. The answer is in that paper. The individuals who had the highest survival were, I can't recall, but I think it was like 30 minutes, 5 times per week, had a significant survival benefit. But yes, I can't give you the answer to that, but the paper I referenced earlier contains the answer to that.
We know exercise helps. That's the bottom line. It's very important. And how about weight? You know, what is I see that in the guidelines around colorectal cancer.
Yes, obesity is an independent risk factor for developing colorectal cancer, sadly. Independent of all the other factors that we spoke about, simply being overweight or obese is an independent risk factor for developing colorectal cancer. Unfortunately, as you know, the majority of people living in the UK are now living with overweight or obesity. And we do need to be very careful around the messaging here. We are not trying to shame or stigmatize anyone or blame anyone. I often say to people, I'm not shaming or stigmatizing any individual. I am shaming or stigmatizing the food culture and the health policies and the lack of education we have around food that means that this has become the norm. And I think this seminar right now and all the seminars we've been running and everything we do at Plant-Based Health Professionals is helping to push back against that in a positive way.
Thank you. Yeah, I completely agree with you, and that's why we're trying to make these resources accessible and available for everyone. Speaking of which, there are so many expensive supplements on the market, and I know you're really passionate about this as well. And I can see so many questions already about supplements and specifically probiotics. And this comes up all the time when it comes to gut health. What is the evidence for probiotic supplementation and avoiding and reducing your risk of colorectal cancer?
Well, in terms of colorectal cancer, there's no evidence. In terms of gut health and digestive diseases overall, Rohini, I think if you'd asked me that question about 3 or 4 years ago, I might have talked about a certain probiotic, maybe VSL number 3 or Vivamix, that might have a role in things like irritable bowel syndrome. But in fact, the data since then has changed my practice. So I no longer recommend probiotic supplementation. The American Gastroenterology Association issued new guidance on the use of probiotics last year. And in terms of adults with digestive health problems, their advice was clear. We should only really be prescribing probiotics if we're doing so within a research protocol to find out if they work. There are a couple of very, very specific indications within the inflammatory bowel disease world where certain probiotics may be useful, but if we are prescribing them to patients, we need to be clear that there is a low expectation of benefit, and these things are expensive.
Yes. And so I think you beautifully covered probiotics and supplements there. Another thing that has come up a few times is microbiome testing. This has become much more popular, and specifically, for people who've got family members who've been diagnosed with colorectal cancer, is this helpful, going for these sort of microbiome tests that are available on the market now?
Yeah, I talked about that paper earlier. There's 2 papers that were published in Nature in 2019, where they took a deep dive into the gut microbiome of individuals with colorectal cancer in multiple countries and multiple food cultures. Now, they found that the gut microbes that metabolize meat and eggs, so generating TMA and secondary bile acids predominantly, that these bugs in your gut microbiome are markers of colorectal cancer risk. So the authors of that paper proposed that we should check everybody's gut microbiome for those bugs and then offer them colorectal cancer screening if they have those bugs in their gut microbiome. But of course, our gut microbiome is incredibly adaptable. And we can switch our gut microbiome from that carcinogenic gut microbiome to the gut microbiome that I spoke about earlier, which is not conducive to developing colorectal cancer, which will help to substantially reduce our risk. As I said earlier, in rural Africa, different gut microbiome, lower levels of bilophilic bacteria, increased levels of bacteria that enjoy fiber. And guess what? Colorectal cancer almost unheard of. among 20 middle-aged volunteers, not one single polyp. So the gut microbial testing is useful if the recommendation that comes at the end of a piece of paper is eat more plants. If it says anything else, then I'm not into it.
I love that side-by-side comparison. We could really see it was laid out plain and clear and simple in that slide. And for everyone who's listening, you will get a copy of the slides in your inbox, but the recording is available for Plant-Based Health Professionals UK members on our website within 72 hours of the session. So one of the questions that's been upvoted so many times, and I have to ask it, is about NHS hospitals still serving bacon and red meat in canteens. Why is this still happening? Patients and staff eating in hospitals are not getting the message about what is healthy and what isn't. Why are hospitals serving bacon and sausages for breakfast when elsewhere in the hospital people are undergoing treatment for colorectal cancer?
Or in the same place in the hospital, people are undergoing treatment for colorectal cancer. That's it. Yeah, as you say, I mean, I'm just saying, you say elsewhere in the hospital, it could be in that same bed. It could be somebody who's been treated for colorectal cancer, given those options. It's sad, it's unfortunate. There's a lot of commercial interests, there's a lot of politics involved. I think, Rohini, maybe it's because I'm not from the UK. I perceive a great reluctance within the UK to give healthy evidence-based dietary advice. And I think there's a great reluctance in the UK to be perceived in any way to be nannying people or making their decisions for them. But hopefully it will change in the future, right?
Yes, hopefully with all your efforts and with Plant-Based Health Professionals UK and lots of other incredible individuals and organisations trying to raise awareness of this. There's a specific question which you did touch on in the presentation about, are there any figures for people of ethnic minority backgrounds? We now have a young second generation of, for example, Asian people who have adopted the Western style dietary pattern, a standard British diet or American diet. Do you have any thoughts about that? And
absolutely. I mean, the data that I showed earlier about Japanese immigrants to the US, that was particularly immigrants to Hawaii. I mean, we know that immigrant populations living in areas like Hawaii, for example, actually have overall poorer health statistics than other groups living within those areas. And I think that's really complex. Of course, it plays into socioeconomic deprivation and just lack of access to healthy food, lack of access to good health care. In the US, lack of health insurance is really important. You know, last year, Rohini, as you know, the American Medical Association wrote a letter to the US Department of Agriculture. The US Department of Agriculture at that time were finalizing the new dietary guidelines for Americans. Now, if you get the US Department of Agriculture, whose number one goal is to remove barriers to profitability for food producers in the US, if you get the US Department of Agriculture to write your healthy dietary guidelines, you know, it's not, you may expect that the science and health is not number one on the agenda, okay? Certainly other interests are at play. But the American Medical Association wrote the USDA and asked them to stop putting dairy and meat as mandatory food groups within the US dietary guidelines. And the reason they asked them to do that was because these foods are linked to increased risks of breast cancer, heart disease, prostate cancer, and colorectal cancer. And in the US, all of those diseases disproportionately affect people of ethnic minorities. So they were asking the USDA to remove this institutional and historic racism from the dietary guidelines. Did the USDA do it? Not really. A lot of red meat in the US dietary guidelines, and even the US dietary guidelines description of a healthy vegetarian approach to food includes 3 servings of dairy per day. But interestingly, as you know, they make no health claims within the guidelines around those foods, simply pointing to the old food industry tropes of good source of protein, good source of calcium.
it's incredibly frustrating. So one of the things that I've seen come up a lot, and it's in the questions again, and is you talked about whole grains, and of course, you know, we have so many wonderful whole grains here in the UK, and of course, many whole grains contain gluten. Does that increase the risk of colorectal cancer? Because people do seem to have a lot of fear around gluten and think that maybe cutting it out might reduce their risk of colorectal cancer. Do you have any, and is there any evidence about that at all?
There isn't any good data showing that grain consumption, including gluten-containing whole grain consumption, increases one's risk of colorectal cancer. In fact, as I showed earlier in the presentation, the data on whole grains is compelling. There is a dose-response curve here. The more whole grains you're consuming, the lower your risk of colorectal cancer. And that goes for gluten-containing whole grains as well, which are probably the most consumed type of whole grains in high-income countries.
Absolutely, you know, whole grain bread or pasta and things like that. There's so many options, but also barley and there's, you know, all the most commonly eaten grains.
Yeah, and rye and buckwheat and quinoa and, you know, teff and all of these things. You know, they're all good for you.
Wonderful. That's what I like to hear. So how about when people have an ostomy? I think, is it called an ostomy? Yeah.
Yep.
When they have that, is it possible to follow a high fiber plant-based diet when you have that? Is that something that's possible? Because we don't hear too much about that.
So if people have had major abdominal problems, excuse me, if they've had huge sections of their gut that have become diseased or have had to be removed due to Crohn's disease or ulcerative colitis or a cancer, then in many cases you are getting into a very specialist area of nutrition, because individuals who have lost large sections of their bowel may have difficulty absorbing nutrients no matter what they consume, and may need to take specially prepared supplements or food replacements, or even have intravenous food no matter what they consume. Okay? So that can be a very specialist area, but it doesn't mean that all individuals with a stoma cannot eat a healthy plant-based diet. And I've encountered many patients over my years in practice who are eating a healthy whole food plant-based diet and they have an ileostomy and they're doing fine. But look, if you do have an ileostomy, very high fiber foods for some individuals can cause problems, because high fiber foods by their very nature draw fluid into the small intestine. In the anatomical normal situation, that fluid would then arrive in your large bowel, which absorbs all the fluid back into your body and bloodstream. If you no longer have a large bowel, then that fluid will not get absorbed back into your system. And for some individuals, that can cause a problem. My advice is always to those patients is to work with their stoma team and work with a registered dietitian. And if you go to any registered dietitian, no matter how desperate your situation, and you say to that dietitian, I would like to eat the healthiest possible diet achievable for me, that registered dietitian is going to be able to help you.
That's so reassuring. So we really need, in those specific cases, it's important to see a healthcare professional who can really help and address your individual needs, because it is much more specific. But for general people listening to this, you covered the recommendations for people who don't have those specific medical concerns, that we can really enjoy all of those different foods that you talked about: fruits, vegetables, whole grains, beans, nuts and seeds, that people have a lot of questions about in the Q&A box, about specific things like iron and calcium. But I want to assure you that we have all of these answers on the Plant-Based Health Professionals UK website. We have more videos and recordings from Dr. Alan Desmond, from other incredible healthcare practitioners, nutritionists, dietitians, and so on. Our fact sheets are great for GPs and other doctors and healthcare professionals to circulate to patients. They cover everything from type 2 diabetes to pregnancy to specific nutrients that you might be interested in. So we can't go through all of that, although I could easily Alan does know everything about all of this. I could definitely ask you, but I think we'd be here all night. So I just want to assure everyone that our website is packed full of information on that. So Alan, before we wrap up, I'm just going to run a quick poll to get everyone's feedback. So if everyone could.
Okay, cool. Can I vote?
That. Unfortunately not, you and I can't vote. But I want to, wrap up by talking about your incredible book and all the things.
Oh, thank you.
So this book came out in January. It's incredible because it's one of two, along with Dr. Gemma Newman, who's another ambassador for Plant-Based Health Professionals UK, two books that are really fantastic if you're in the UK, because all the measurements are in grams, all the ingredients are available in, I think you looked at, your average UK supermarket, didn't kind of Tesco or Sainsbury's or something like that.
Yeah, we really want to make sure. I think sometimes when people decide to make the switch to plant-based diet, A, it can be intimidating, and B, they feel like they need to go to the health food store and buy all these ingredients they never heard of before. So when we wrote the recipes here, we were very careful to include, familiar foods and familiar ingredients to produce familiar meals. And every recipe is fully illustrated, and it tells you how much fiber and how much protein and how many unique plants you have just eaten when you consume that meal. So we've made it really, really simple for people. And I mean, I've eaten every recipe in this book many times, and we still cook from this book all the time in our own kitchen. Because the recipes are great. And the book's actually out in the US this month. So it has its US and Australian release on the 18th of May. So it's in Amazon and Barnes and Nobles and anywhere that sells books, basically. You should be able to grab a copy.
That's wonderful. Yeah, it's so colourful, it's so beautiful, and there's lots of little nutrition tidbits throughout, which are really great. It's really accessible to everyone, even if you're totally new to a plant-based diet, but even if you are already eating this way, it's just new inspiration for your kitchen and everything. So I'm really glad to see that. But for everyone who hasn't read it, then I highly recommend it. And for those of you who want to keep in touch and learn more about Dr. Alan Desmond's work, can I ask you, where can everyone reach you? What's the best way to keep updated?
Yes, yeah, absolutely. I mean, I'm on Instagram at Dr. Alan Desmond. If you just type my name in, you'll see the space. That's me. And if you want to learn more about the book, if you go to alandesmond.com/revolution. And yeah, that's it. I don't really have enough time to be across all platforms, Rohini. So I keep it pretty tight.
Yeah, so definitely Instagram and your website has everything, but you're also on lots of brilliant podcasts. So if anyone is into podcasts, then just type in Dr. Alan Desmond, they will come up, and you can, because a lot of people had specific questions about other areas which you also specialize in, like Crohn's disease and ulcerative colitis, inflammatory bowel disease. There's so many different topics that you could talk about, but we would want to really focus in and hone in on colorectal cancer in this session. But those podcasts cover all of that, so I urge everyone to go and listen. But thank you so much for giving us your time. I know you've been incredibly busy since the book launch and working really hard getting everyone in your practice to try out a plant-based diet and everything. So thank you again for giving us your time, and the comments have been incredible. I haven't been able to get through all of them, but I will send you some afterwards.
Oh, thanks, Rohini. And again, thank you so much for all your efforts organizing these webinars. They're incredible. I'm just really glad I could contribute. Thank you for inviting me.
Thank you so much. And for everyone else, hope to see you in a couple of weeks, because the webinar with registered dietitian Brenda Davis on type 2 diabetes is going to be incredible. We're going to cover some new studies that have come out in the last year as well. So if you already know a lot about the topic, it's still going to be really really worth watching. So hopefully see you on Thursday 20th of May. But for everyone else, good night, and thank you for joining us.